Hi everyone, welcome to Dermpath Talk. With us today is Silvija Gottsman, dermatologist and dermatopathologist at Northwood Hall, New York, founder of the first online Dermpath Journal Club. And also with us is Farhad Riyaz, dermatologist and Mohs surgery fellow at Northwestern Memorial Hospital in Chicago, founder and administrator of this group. Welcome guys, and Farhad, congratulations, you're almost done with your fellowship.
Thanks so much.
And Silvia, excellent work you're doing with the online Dermpath Journal Club. Could you explain us how can we find the club and how can we participate on it?
Thank you, Manuel. Thank you so much for inviting me here. As you mentioned, I'm a dermatologist, dermatopathologist. I work at Northwell Health in Long Island, New York, as an assistant professor of dermatology and pathology. And I have great passion in social media education. That really followed after the inspiring talk by Dr. Jared Gardner that I heard once long ago at one of the ASDP meetings. And when I became a board member at the American Society of Dermatopathology, a social media subcommittee, there was an idea that was born to create a dermatopathology journal club. Already in the social sphere of pathology education, there was a very thriving general pathology journal club. So we thought that we could take on that challenge and provide cutting edge articles, provide open access, and invite participants not just from the US, but from all over the world. I've had over 185 individuals from more than 15 different countries, and it's been fantastic to interact with pathologists from different countries with different types of education and different types of resources, and hear and learn actually from each other. So we featured one of your articles a couple of months ago, so thank you for joining us. And it's Dermpath JC, and whoever wants to join us on Twitter, they can reach out to me, and I'm happy to talk to them more about it.
So today we're discussing dermatology fillers in dermatopathology sections. And Silvia, could you teach us about the findings that we see in this type of cases?
Yeah, absolutely. I think it's a very interesting topic. We are encountering more and more often in our not daily sign-outs, but certainly weekly and monthly sign-outs. These cases are not too common, but since the turn of the century, dermatologists have seen increased numbers of patients for cosmetic procedures, so much that some dermatologists have completely focused improving the appearance of the aging skin. So in dermatopathology now more than ever, we get specimens not only from dermatologists, but also from primary care providers, podiatrists and plastic surgeons. And many times, as you may know, we get limited clinical history, and sometimes knowing the specific histologic findings of dermatologic fillers can help us get to a diagnosis without any clinical information. But before I dive into the histologic findings, I want to draw your attention to this fantastic table from Dr. Requena. It was published in the Journal of the American Academy of Dermatology. And it's a fantastic paper that summarizes the most common injectable fillers for soft tissue augmentation. And he has kind of divided them into these three groups, the top two being the resorbable fillers and ones that are resorbable within months, the ones that are resorbable within years. He's tabulated the chemical composition and the trade name. And then also he's listed some of the permanent fillers. So on average, the resorbable ones within months, it's a 4 to 6 months resorption. And the ones that are within years, it's 9 to 24 months. So we're looking at 2 years, where permanent ones are more permanent. And the ones that I have put check marks next to are the ones that I'm going to show you. So the first one is bovine collagen. Bovine collagen is a resorbable filler. Its duration is less than 6 months, and it has very distinct histologic findings that are very neat and quite beautiful, in my opinion. The bovine collagen bundles are much thicker than human collagen, and so this is the epidermis over here. This is the papillary dermis on top, reticular dermis, and then you have the subcu fat. This was injected in the subcutaneous fat, and then the collagen bundles, the human collagen bundles, are more loose, but the bovine collagen bundles are thicker. They are less cellular. They have a more of a homogeneous appearance, and there's almost without any spaces in between them. And then over time, they do form that palisading granulomatous reaction. These are histiocytes that are surrounding the bovine collagen. So as you can imagine, the histiocytes, are chomping away at the bits of bovine collagen, and over time, over 6 months of time, the bovine collagen is decreased in size considerably. A fun fact, bovine collagen is not birefringent under polarized light, whereas human collagen it is. So that is another thing that you can use in Dermpath sections to prove that it's bovine collagen. Maybe Farhad can talk about this. Skin tests are required before injection with bovine collagen because 3% of the population develops a delayed hypersensitivity response, and some doctors recommend 2 tests 2 to 4 weeks apart. So that's a bovine collagen, palisading granulomas in the subcutaneous fat. Another fantastic, this is probably the most common filler that I see in Dermpath section, and this is a hyaluronic acid filler. So hyaluronic acid perhaps is not too foreign to us, since connective tissue fibers are normally embedded in an extracellular matrix whose key ingredient is proteoglycans. Those are core proteins that are complex with glycosaminoglycans, and those are hyaluronic acid, dermatan sulfate, heparan sulfate, and chondroitin sulfate. And the main function of the hyaluronic acid is water absorption. It can absorb up to 1,000 times of the volume. It can have shock absorbing properties, and lubrication between collagen and elastic fibers. But with aging, there is increase in dermatan sulfate, and there's decrease in chondroitin sulfate. And so you can imagine how there would be loss of volume clinically, and how some patients will want to correct that. Of course, Manuel, as you know, and you have seen in Dermpath cases of your own, when there's pathologic accumulation in acid mucopolysaccharides, that's due to deficiency of lysosomal hydrolysis that normally cleave these glycosaminoglycans, and those conditions are lupus, and granuloma annulare also has increased mucin. So there are very, very few hypersensitivity reactions described with hyaluronic acid fillers. However, one of the most common ones is still being a granulomatous types of reaction. Yet still in most of 9 out of 10 times when I see hyaluronic acid fillers, I don't see a very robust granulomatous response. And then here I'm going to try to use my arrow again. And I use this low power image to just give you a reference of the size of these things, because they may appear pretty big when this was a woman who had nodularity in her lower lip. Basically that was all the clinical information that we were provided. We were not provided information that she had undergone soft tissue augmentation. However, we were able to recognize these bluish amorphous deposits that again are quite beautiful in my opinion. And then after reaching out to the clinician and asking, well, is this what had happened to the patient? Did the patient recently have fillers? And we were able to get a clinico-pathologic correlation. Here's another close-up of how amorphous and acellular these bluish globules look like.
Nice photo.
Okay, thank you. Okay, so I think we're gonna just keep moving. Here's actually a photo that I like to share from the American Society of Oral Pathology and Maxillofacial Pathology, and they're an excellent resource for seeing more fillers in oral pathology sections. So as you can see here, we don't have a granular layer and we don't have a stratum corneum, and there's almost a pale look to the spinous layer, so that's a clue that we are on mucosal skin. And again, we see those basophilic globules, those deposits with which, and this was listed as Juvederm as the hyaluronic acid filler. Okay, so the next one that I want to talk about, it's a quite famous one. So it's poly-L-lactic acid. It's used to it was approved to correct lipoatrophy in HIV patients. It's biodegradable, but tends to stimulate proliferation of dermal fibroblasts. And over 8 to 30 months after the first injection, there's ingrowth of type 1 collagen. So this filler is in the resorbable fillers that tends to stick around for a little bit longer, and it's degraded over a 9 to 24 month period. 30 to 40% of patients, unfortunately, do experience nodules after injections. And you can imagine how that could happen, because look at this robust granulomatous response. Histologically, we see these translucent particles that are oval, they're fusiform, they're a little bit spiky, and these are indeed birefringent under polarized light. So they would look very, they'll be easily highlighted with polarized light. This is just a low power view of the exact same case, also from the American Academy of Oral Pathology and Maxillofacial Pathology. The next one that I want to talk about, this is a fantastic photo from Dr. Greg Hostler from Dermpath in Dallas of calcium hydroxyl apatite. So this is easily known as Radiesse filler. So it's a resorbable filler. These are little tiny microspheres that are quite uniform. They have bluish to grayish color. And some authors say that they simulate almost no granulomatous response, but I'll leave that up to you, because in both of these cases, mine and Dr. Hostler's, there's a pretty brisk granulomatous response to them. So calcium hydroxyl apatite, it's a favorite question, I feel like, for the boards, because they like to test about the radiologic findings. And this is a axial view of a CT scan of the head for some unrelated reason. And these are the calcium hydroxyl apatite spheres that they're easily highlighted on the CT head scan. They have higher incidence of nodules when they're injected into the lips as opposed to other areas on the face, and perhaps that's one of the reasons why hyaluronic acid fillers are more commonly used to augment the lips than calcium hydroxyapatite. Okay, next case that we're going to talk about is silicone. So silicone and silicone granulomas. Silicone is a hydrophobic compound of dimethyl siloxanes. So it can be injected as an oil, a gel, or a solid silicone. So it's most widely studied filler material. It can have local reactions that can include erythema, hyperpigmentation, sometimes even hypopigmentation, paradoxically, inflammatory nodules, ulcerative, and even migratory lesions. From some of the more severe adverse reactions is seromas, infections, pulmonary embolism, and other rare systemic complications. The histology is quite gorgeous, because we have these little cystic spaces that are of variable diameter that almost simulate adipocytes. but they're sometimes you'll be able to see some of the silicone retained with them, but sometimes these may appear hollow, like these larger ones, because the silicone oil has fallen out during processing. But basically the key is whenever you see granulomatous reaction in the dermis with cystic spaces of variable sizes, you want to think about silicone granuloma. However, one would think, well, could this be a liposarcoma? And of course, you just have to make sure that there are no lipoblast present in the section to not miss that terrible diagnosis. Here's another very interesting case of a silicone granuloma that we had written up for the American Journal of Dermatopathology. And this indeed was a metastatic silicone granuloma that had caused not only ulceration of the skin, but also erythema and induration. And this lesion in particularly is on the right anterior thigh, and the silicone had migrated from 6 years after a silicone injection in the buttocks. And similar to the section before, this is more of a low power view. There's a little bit of dermal fibrosis. There is a lymphoplasmacytic infiltrate that's probably better appreciated here. And there's also histiocytes surrounding cystic spaces of variable diameter that appear hollow because the silicone had fallen out during processing. Luckily, the patient was able to remember that it was silicone indeed, that it was injected. Another very, very similar filler, this one is a permanent filler that we can sometimes see in Dermpath sections, is paraffin, and this has been called paraffinoma when it involves the shaft of the penis. It's been called sclerosing lipogranuloma, and is essentially, again, granulomatous response with cystic spaces of variable sizes. It will be very difficult, in my opinion, to differentiate between a paraffinoma and a silicone granuloma. It has been said that in paraffinomas, there's a little bit more sclerosis surrounding these lesions, but history in the end would help. Just like so many, times we have differential, it's clinical pathologic correlation that matters. And again, this is a fantastic case that Dr. Hostler has shared on Twitter. So one other one that I personally haven't seen, but I was intrigued by this image, and I wanted to put this in succession after the silicone granuloma and the paraffin granuloma, because the granuloma from the polymethyl methacrylate microspheres, it's a little bit easier to distinguish because these PMMA microspheres are markedly homogeneous in size and shape. And again, of course, they can simulate adipocytes like the other two, but since they're more homogeneous in size, then it would be easier to say, okay, this is probably a granuloma from article, versus if I have something that has variable sizes, it's either silicone or paraffin, and let me get more history. So these polymethyl methacrylate microspheres, they're suspended in bovine collagen solution. And like we talked about earlier with bovine collagen fillers, for this one too, intradermal tests are also mandatory to identify patients with potential risk for allergic reactions. Rare episodes of anaphylactic shock have been described in literature. That's why it's very, very important to know which patients that you can perform this on and which patients you should avoid using this. So last but not least, I wanted to talk about the Gore-Tex synthetic implants. I honestly never saw this in dermatopathology sections until I did my surgical pathology rotations as a fellow, and I saw this very curious thing that I couldn't quite put my name to it, but I knew that it was foreign. And as you can see here, it's surrounded by histiocytes and giant cells. And my wonderful attending at the time taught me that this was polytetrafluoroethylene, which is the main component used to make vascular grafts. But apparently, it has been used for permanent facial augmentation by plastics and maxillofacial surgeons. Dr. Mark Berman was the first plastic surgeon in the world to use this in 1983, and it is FDA approved for subcutaneous augmentation since 1994. And these are some of the results that he has shared on his website, but these are the histologic findings and has actually quite beautiful pattern under polarized light. So those are quick 8 dermatology fillers in dermatopathology sections, and I hope in the future, if you encounter these when you're looking at unknowns or where in your daily sign-outs and you don't have access to the clinical information, that you will be able to recognize them. And Manuel, thank you so much for listening and for inviting me.
Silvija, thank you. Very interesting talk and very awesome, fantastic photographs. And definitely we have to be able to recognize kind of the clues of these type of fillers, because reactions form maybe 1 or 2 years after the patient has been injected, and patients don't remember what type of filler or it was used. So it is very helpful to identify the features of this. So thank you so much for joining us today for this interesting topic. And thank you guys, and looking forward to talk to you in the next edition of Dermpath Talk.